Today I'm going to talk about the haematological manifestations of SLE. So before we plunge into the topic here, we'll just look at SLE as an overview. So SLE is a chronic inflammatory disease of an unknown cause that can affect virtually every organ in the body. The production of a number of anti-nuclear antibodies are a prominent feature of the disease, and the clinical course is quite variable. So some people have acute flares with relapses, and other people have a more chronic indolent disease. Women are more affected than men, particularly in the 20s and 30s. Patients often have a wide range of symptoms. Constitutional symptoms are the most common, and people often have some dermatological and musculoskeletal complaints, and often have mild hematological and serological involvement. The pattern that dominates early in the disease tends to be the pattern that someone's going to get for the rest of their illness. The ACR criteria from 1997 is, in my opinion, the easiest one to remember for the diagnosis of lupus. You need 4 out of 11 at some stage. And my mnemonic was SoapBrain MD from Wikipedia. That's now been updated to this SLIC criteria, which still needs 4 criteria. The thing that's changed now is one of them could be clinical, one of them has to be laboratory, or you can have biopsy-proven lupus nephritis with a positive ANA or anti-DNA. So this is from 2012, and has slightly shifted the goalpost to be a little bit more inclusive. The upside of this is it increases the sensitivity, so you're picking up more lupus than before. And the cost of that, though, is you're getting decreased specificity and probably overcalling it. So covering lupus in one talk is not really feasible, and today we're just going to talk about the hematological issues. So anemia is a very big problem in lupus. About 50% of people end up with anemia at some stage. Leukopenia is also common, and we define that as white cells of less than 4 or lymphocytes less than 1.5. And thrombocytopenia occurs in up to a quarter of patients, as defined as platelets of less than 100. And finally, antiphospholipid syndrome gets clumped as one of the hematological problems with lupus. So just narrowing down on the anemia now. There are many factors that contribute to anemia in lupus patients, and unfortunately it's a huge list from medications, blood loss, dietary problems, renal problems, inflammation, all the way through to hemolysis and infection. A simpler way to try and break that down is to look at them from an immune point of view and non-immune things. So from an immune point of view, we have autoimmune hemolytic anemia, pure red cell aplasia, hemophagocytic syndrome, aplastic anemia, TTP, and Evans syndrome. Then on the other side of the coin, you've got the non-immune things such as the anemia of chronic disease, the renal disease, iron deficiency, drug problems, infections, and myelofibrosis and myelodysplasia can occur. So if we go through the pathophysiology, looking at the non-immune causes, anemia of chronic disease is a problem with hepcidin, which basically internalizes ferroportin, which traps iron to whichever cell it's in at that stage in the body. And then there's also inflammatory cytokines that depress proliferation and differentiation of precursors. Renal disease is basically a problem with EPO, and iron deficiency can come from chronic GI or menstrual loss, which can occur with the agents we put people with lupus on, but also anemia of chronic disease will eventually cause an iron deficiency picture. Looking at the immune causes of anemia, they basically can be summarized as antibodies to all stages of red blood cell development. Leukopenia in lupus can also be divided into immune and non-immune causes. So the non-immune things, if there's no other organ involved, think of a medication side effect, but also keep in mind that severe infection might also be occurring, and that tends to happen to people with high-dose steroids and immunosuppression. From an immune point of view, again, the answer is antibodies, so that you can get cytotoxic anti-lymphocyte antibodies, as well as anti-neutrophil antibodies. The other thing that occurs in lupus is increased apoptosis of white cells, and that's basically due to upregulation of Fas antigen, which is part of the tumor necrosis factor family on the surface of T cells. The other thing to bear in mind is that absolute lymphopenia can correlate with disease activity, and we've known about this since 1978. Thrombocytopenia is either going to be a problem with bone marrow and not enough production, peripheral destruction, or things getting stuck and chewed up in the spleen. Medications can cause problems at all of those stages. Antiplatelet antibodies would cause peripheral destruction, and then antibodies to platelet precursors such as anti-TPO and TPO receptor antibodies that could cause problems in the bone marrow. So now that you've got this patient that has cytopenia, how do you begin to try and figure out what's going on? So usually you start with a repeat FBE and a medication history. Commonly implicated drugs include cyclophosphamide azathioprine and methotrexate. Other drugs that can also cause problems that we don't often think about would just be NSAIDs, ACE inhibitors and antibiotics, for example Bactrim. If someone has an isolated cytopenia in lupus, it's almost always a peripheral destruction, and if someone's pancytopenic, it's probably a bone marrow problem. So the further investigations really depend on what you've got so far, but you can look at leukocyte morphology, check the bone marrow biopsy, looking for any problems with maturation, look for any infection, and always keep in mind one of the rarer differentials such as a macrophage activation syndrome, antiphospholipid syndrome, and autoimmune hemolysis thrombocytopenia. The management of these conditions, well, if something's mild, we tend to try and leave it alone because you'll probably cause more problems than good. So if a leukopenia is greater than 2, we'd usually leave it. If a thrombocytopenia is stable and greater than 50, it's probably not going to cause any major problems. Always try and rationalise the medications and investigate further if there's any acute change in one of the parameters. A good general approach is to try and look at the lineages separately. So if someone has iron deficiency anemia, find bleeding and replace the iron. If someone has anemia of chronic disease, they may benefit from EPO, but having said that, there's no real study of EPO in lupus to sort of back that up. And renal disease, we obviously would try EPO as well. In white blood cells, we'll talk about that in its own sort of slide later on, but there is the topic of febrile neutropenia in lupus and whether or not we should be using GCSF in those cases. There was one case series where they had a relatively favourable response, but there's quite a bit of theoretical and probably some case report concern about increasing the immune response and getting renal flares and vasculitis. From the platelet point of view, it's managed similar to an ITP. We basically try to avoid transfusion if it's an immune-mediated cause. Steroids are first line, even more so than normal ITP. And then you've got your other things such as IVIG, rituximab and splenectomy as second line options. Splenectomy's actually got a relatively durable response at 6.6 years. About 2/3 still have a sustained or complete response, but half still need a little bit of pred. And there's no trials really to guide about what you should do in this situation. If we look at the traditional treatments that have been tried for lupus and cytopenias, corticosteroids have a rapid and potent response. They're initial treatment for many patients and they work really well for pure red cell aplasia, hemolytic anemia, and thrombocytopenia. However, the long-term outcome is not predictable, and there's no controlled studies for the optimal dosing. For example, we're not really sure whether we should be giving big doses of methylprednisolone, 500 to 1,000 milligrams, or whether we should be giving oral 0.5 to 1 milligrams per kilo. Other traditional treatments include hydroxychloroquine, which is a good steroid-sparing agent and has an additive effect to prednisolone, and is considered the chicken soup of lupus if you listen to MaxSap, and everyone really should be on it unless there's a contraindication. Azathioprine is very good for autoimmune hemolysis and thrombocytopenia. Mycophenolate is kind of a bottom of the barrel used for refractory cytopenias, and a survey of rheumatologists in the Arthritis Rheumatology Journal found that over half of the people had used that when they were getting stuck. Cyclosporin A is quite good for lymphopenia and thrombocytopenia, and cyclophosphamide is used for thrombocytopenia, aplastic anemia, and TTP. IVIG is quite good for autoimmune hemolysis. Thrombocytopenia is a second-line agent, and in the use of TTP. Plasma exchange is really used for very extreme manifestations of lupus such as TTP, catastrophic APS, pure red cell aplasia, and hemophagocytic syndrome. And finally, romiplostim and eltrombopag, the TPO agonists, are approved for chronic ITP but haven't been specifically tried in lupus. The focus now is on some new treatments, and the recent targets include looking at B cells, looking at B cell to T cell co-stimulation, and also the interferon alpha pathway. There's quite a good rationale for them, but the results have been mixed, unfortunately. So if we start with the B cell, a lot of research has gone into rituximab. So rituximab is an anti-CD20 antibody, and the big trial we have this is the Explorer trial, which unfortunately showed no difference in major or partial clinical response in people that were already on aggressive background therapy. Despite this, due to no better alternative, it's sometimes tried. So that trial is from 2010. The other thing looked at is this thing called the B lymphocyte stimulator, and we now have an antibody called belimumab against that. And there's been two big trials of that, the Bliss-52 and the Bliss-76. And the Bliss-52 looked at belimumab against a placebo, and at 1 year things looked pretty good, but at 76 the treatment difference was heading straight back towards showing no significant difference, so it was a bit unfortunate. So we need to have a little bit more information about that. Ebrutuzumab is an anti-CD22 antibody, so it's not really a depleter. It basically is meant to be a modulator of B cell function, and the EMBLEM trial showed some significant reductions in index scores compared with placebo. But it was a very small trial, so they need to have bigger studies. The other thing too is to look at the B cell, T cell co-stimulatory ways and the T cell stimulatory pathways as well. So we have abatacept, which is a CTLA4 molecule, and basically this is a way to try and turn off the immune stimulation of T cells. Unfortunately, that's had a relatively disappointing response so far. The things that we'll be looking at for the future are things like interleukins and interferon pathway inhibitors, but none of them have really transferred through to clinical practice at this stage. So then we get to the stage where you've tried everything else. Is there anything else you can do? And that's where stem cell transplants have been looked at in the past, but it's really looking at a reboot of the immune system. So from a stem cell transplantation point of view, from a hematopoietic stem cell transplantation, you can either have autologous or allogenic. Both have been looked at in people with lupus and autoimmune disease. So this large trial with Farge et al. Looking at autologous transplants looked at around 900 people that had autoimmune diseases from a variety of conditions, and about 10% of them, 85 patients, had lupus. And there was some promising results at 5 years, but it did have significant risks. So the progression-free survival was 44%, so some response, but not amazing. And up to a quarter of people who have died. But these were people that were very treatment refractory to everything else. From an allogenic point of view, there's not as much information to go on. So there's one study here that looked at 15 people with refractory lupus, and all of them had a response and had significant decreased SLEDAI scores at 12 months. But again, it's a very sub-select sample. Obviously, allogeneic has a lot more risk than autologous, and both of these treatments have a relatively high mortality, so therefore only considered for really truly refractory cases. So I think that's about as deep as we're going to go into today, and it's just a chance now to look back at it all. So cytopenia in lupus is complicated and has a very broad differential diagnosis. The evaluation involves reviewing the current medications, rechecking the FBE, and consideration of a bone marrow biopsy in pancytopenia. Keep in mind that a mild cytopenia doesn't usually need any specific treatment. Corticosteroids are the first choice for moderate to severe immune-mediated anemia and thrombocytopenia. And immunosuppressive medications are then used for either steroid-sparing effects or whether steroids don't work and you're getting severe and refractory cases. The newer agents are out there, but really need a lot more investigation before we can incorporate them into mainstream practice. So here's the references I've looked at to try and prepare this today. Thanks for listening.